expert in financial and banking services. Though with his political legacy starts from the Justice Party, his parents, everyone was there, and the political legacy kondundalum. Sir, with this much experience, he started his undergraduation from NIT and moved on to MIT. With almost, if I remember correctly, more than 60 countries, he was giving a banking solutions. So he could decode the banking complexity of more than 60 countries. Is an unimaginable expert. In fact, I used to admire him when this, he was at the time, he was in the opposition also. When the petrol prices were revised, I understand it's the first time that I heard about elasticity of the money in the bank. Petrol, I never heard. And next time also, when he was in opposition 2016, when the budget was presented, he could decode and give meaning to each and every word. And that's unimaginable for any politician, the real expertise, sir. And your role in IT sector, I remember only one incident where in the recent collectors conference, sir vandu modalla kettade vande, let us put in HIMS in the PHC. See, this is going to be the game changer, because he understands the value of the data. With this small intervention, there's a huge number of budget savings he could do it. And in fact, the structural reforms which he brought in is the critical for the state finance right now. We welcome you on each and every one of you, sir. We request your support on few things like how we can give an additional financing for the primary care, how we can utilize other resources like CSR, or how we can become more IT in the primary care sector. Welcome you, sir. Please, sir.
அவைக்கு வருகை தந்திருக்கும் மதிப்பிற்குரிய மதுரை மாநகராட்சி மேயர் அவர்களை அன்புடன் வரவேற்கிறோம். மாண்புமிகு அமைச்சர் அவர்களுக்கு பூங்கொத்து கொடுத்து பொது சுகாதாரம் மற்றும் நோய் தடுப்பு மருந்து துறையின் இயக்குனர் மருத்துவர் TS செல்வ விநாயகம் ஐயா அவர்கள் வரவேற்கிறார்கள். நன்றி ஐயா.
Good morning to all of you. Thank you for inviting me to this annual conference, which I'm very glad to note is being held in Madurai this year. I want to thank Dr. Selva Vinayagam, who has organized this conference, who came to my office to invite me in person, and who was kind enough to suggest a few topics that I should cover today. But maybe I should start a bit back in history and talk about some of the good things about public health in Tamil Nadu and some of the things we need to pay a bit of attention to, in my opinion. So the good things are, I think, because of the notion of inclusion, of social justice, of equitable access, of education as the basis for progress and for communal harmony. Tamil Nadu has excelled in the medical education field. Even today, I think we have the most number of government medical college seats in the country. We have almost an overabundance of doctors, I would say, where our ratio of doctors to patients is better than the United States, better than most OECD countries, and is somewhere around 4 is to every 1,000, which is far greater than the national average. So these are all the good things. And yet, I would say, at some level, we have not yet achieved best-in-class outcomes, whether it's infant mortality, whether it's maternal mortality, whether it's the speed with which we dealt with the COVID pandemic or the vaccinations. Smaller states like Kerala did better than us in some ways. As the director mentioned, I used to have a different portfolio, and when I was in that portfolio, I remarked multiple times that after education, the greatest spending in the state of Tamil Nadu was for the health department. Again, I would say we have many good things to show for it. Relatively speaking, we have good primary health network, relatively good rural coverage, relatively good urban health centers. But we had a lot of room to improve. On the positive side, again, I would say that during the COVID pandemic, we discovered that we had a certain resilience and the ability to leverage the existing resources we had better than most people. And some of you may have seen the Lancet study that was published by our overseer, Dr. Chandramohan, that in Madurai we took a bunch of really sophisticated, politically sophisticated initiatives. My fellow minister Tirumurthy and I, we discovered where the bottlenecks in the system were, and I want to use this as a case study for how administration is as much of the battle as anything else. So we discovered there were 2-3 weaknesses in the system. The first was that there was serious overcrowding in the GH. The GH had become the magnet for everybody with symptoms, and so all of them used to come, and we were creating an epicenter of infection at the GH itself. Second, because of the kind of community we have, where if somebody gets sick, the whole family rallies around them. When one sick person was coming, they were being accompanied by 2, 3, 4 people, and so we were bringing this multiple kind of risk factors all together because of the big crowd. The second problem we had was that the time taken for a sample to be validated and given a result was running anywhere between 18 and 24 hours. And the third problem we had was that by the time the results went, we were getting people aggregating out of precaution and having serious spread risk again. Of course, we had a lot of issues with oxygen, but I won't get into that right now because we had the wonderful help of somebody very close in Orissa, and we were able to, at the last minute, start getting a daily supply of 80 metric tons sent by train. We were able to avert a lot of the problems that came from the union government cancelling all cross-border oxygen contracts overnight. But the interventions we did beyond that, the 2 major interventions I would say is, with the help of my colleague, we used the local self-help groups, about 4,000 women in the villages, without waiting for people to come to the primary health center or the GH with symptoms. We had these volunteers go and check for people with symptoms house by house, door by door. And when they found people with symptoms, we set up 10-bed, 5-bed facilities in every panchayat with just oxygen, nothing else, a nurse and oxygen, and medication where we had medication. And we had these people shifted to those places, and we greatly reduced the number of people coming to the GH. We also actively discouraged families from coming, and we started providing free food at the GH to those who came with symptoms or those who came for treatment. And so they didn't have to have somebody else come with them to help them get food or to eat or so forth. And then the other thing we did was we discovered that the reason the tests were taking so long was not that we had too few test centers, but all of the samples were getting batched and coming at one time in the day. And at that time in the day, the actual test processing machines were too few. So we had enough centers, but we had all tests coming at the same time, and we had too few machines. So with a bunch of CSR funding, we actually increased the number of machines 3-fold. Same number of centers, but in each center we now had 3 test machines. And we changed the frequency at which samples would be collected and brought to the testing centers. And we were able to bring that processing time down from 18-24 hours down to about 6 hours. And keep it all on the internet so they can check before they come to the hospital which building should I go to if I want to get treatment for my wound. The second thing I said is that if we have an integrated system that starts from primary care all the way to coming to GH for, let's say, very complex surgery, we must have a patient information system that is seamless across all these levels of care. And you must be able to without violating the privacy norms, have the patient's information from the village where they first went with the symptom to the specialist doctor at the Chennai or Madurai GH, be able to pull this up on their computer and not have to expect the patient to either keep on reiterating their symptoms and their story or to carry all their test results and their documentation with them. And the third thing I said is we must have what I now understand you call HMIS because it's been attempted and failed multiple times, but what in most parts of the world, like the NHS or the US medical system, would consider a good hospital administration and a healthcare system administration, platform. We don't know how many doctors are working at what place on what day. We don't know how many CT scans are actually functioning. We don't know how many X-rays are taken. We don't know whether the machine is, at actual utility or it has been bought and not yet commissioned. Is it actually in service or in repair? So these kinds of things, unless we get right, I get my perception, I may be wrong, you're all in the field, is that as much as Tamil Nadu spends in its health budget, we could be getting a lot better outcomes for this spending were we to improve the administration better. And some of these will require this data, as many friends of mine in the financial industry have pointed out and have shown me. If you look at both the UK system and the German system, state-funded healthcare improved dramatically when each unit was made its own P&L center, or rather each unit was made its own cost center because there's no profit. So in the NHS, they can tell how many heart surgeries are done in King's Hospital as opposed to Queen's Hospital, how much did it cost, how many surgeons were employed, what is the average waiting time, how many patients are seen, these kinds of statistics that we simply don't have. And we need these to really improve the effectiveness of our spending and ensure that we are allocating resources more efficiently to those places where the results are substantively better. Sometimes it's a question of distribution. So for example, in my MLA constituency, which is Madurai Central, one of the things I did when first encouraged by the COVID reallocation model in the MLA CDS, but I've continued that since, is to set up radars, Doppler and other scans in the primary health centers. So we have both basic ones, 5 lakh, 8 lakh, and slightly sophisticated ones, 16 lakh, 20 lakh, in the primary health centers and secondary health centers around my constituency. And by the utilization of those, where I find 20, 30 people a day are getting scans, it really gives me the comfort that A, it is easier for them to reach a center close to them. B, it reduces the number of people coming to the GH and having to wait in line. And C, therefore, it increases the efficiency of throughput of how quickly people can get the information they need about the health of their baby or the stage of their progression of disease or whatever it is. So I think collectively, if I look at it purely from a financing of health perspective, the first thing we need to do is greatly improve the technology. I brought this up, as the director said, in the collectors conference with the chief minister there. I was assured by the new finance secretary that this is something they're going to focus on this year. It was certainly something I focused on a lot when I was finance minister. But also, I think we need to think about how we fund this healthcare. Right now, 100% of it comes in allocations from the central budget. In many countries, they make sure that taxes on products that lead to health problems, whether that's tobacco, whether that's alcohol, whether that's high sugar drinks, some of these taxes are directly allocated so that there is a kind of causation and recovery relationship between those kinds of practices or goods that create the problems and the health treatment that is required as a function of it. I think also, depending on the situation, we learned during COVID, for example, that CSR was a great source of funding. Hundreds and hundreds of oxygen concentrators, other equipment. In fact, The test devices we got that I told you, we got 100% of that under CSR money rather than waiting for the state. And the great luxury of CSR money is that not only is it a financing option, but in many cases, the industrialists and the big corporates that have access to these funds also have access to supply routes and supply chains that the state doesn't have. When we built our in-house oxygen plants, many of them were because the industrialists were able to find and source the oxygen generators and the compressors and the tanks faster than the state could do it. And if the state does it, we have to go through a whole tender process, and we have to kind of delay things for the sake of showing transparency sometimes, which is very important. So I think overall, if I was to just wrap up this theme, as well as we think the model of social inclusion and equitable access has worked for us in Tamil Nadu, at least relative to the Indian benchmark, we must improve a lot of things. We must improve the efficiency with which we spend money. We must improve the information available to help us make decisions and to allocate resources. And we must make it easier for the average citizen to access the resources that the state provides. And I have another example. Madurai GH has one of the better ophthalmological units that I have seen. In fact, it has really, really good services, and there's usually capacity. What surprises me is that the utilization rate of the beds, at least the few months that I was looking at it when I was an opposition MLA, was probably 15%. So we have all this capacity, and there are not enough patients who are coming. Is that because the patients don't exist and they don't need them? If so, we have built too much capacity. It was inefficient allocation of state resources. But in fact, that's not true, because when we ran these camps, that is, we ran the screenings at local areas within my constituency, every time we ran a camp, we found tens of cases that needed glasses and probably a dozen or couple dozen cases that needed cataract surgery. And we were able to bring them. Then, of course, as an MLA, I made those arrangements for their transport, for their food, etc. And we were able to bring them, and without any delay, from the minute that they were detected that they needed the surgery to the minute that they got the surgery and went back, was probably less than a week or 10 days. So we have that much capacity built up and available, but we don't really have the efficiency of resource utilization or even access or awareness that I think we need to really focus on. So I think overall, though this might not be the happiest message for many of you, those of you particularly in government service, I would say, as proud as we are of the health system and the health framework that we have, and certainly of the medical education system in Tamil Nadu, and in particular in Madurai, many of you may know that my Periyappa, Dr. T. Subramaniam, was professor of surgery for 20 plus years and trained many of the surgeons between Kanyakumari and here, going back a couple of generations. So as proud as we are of all those efforts and the pioneering work around the blood banks and around the waste management and incineration and all that, we are at a crossroads, in my opinion. We cannot continue to raise the rate of funding anywhere near what we have so far. The state's finances are in pretty bad duress. We are running very large structural deficits. And the pandemic taught us that we need to be much more efficient and much more thoughtful with the administrative side. And if we look around the world, if we look at advanced economies like the US, like Australia, like Canada, like the UK, like Western Europe, the use of information technology, the ability to validate functionality, productivity, to ensure that there's optimization of resources has yielded substantive improvements, both in the public sector and in the private sector. And I think it is the order of the day, particularly in the era of a pandemic, that the state needs to focus a lot on this. Of course, the primary health centers continue to be the backbone. Prevention is far better than cure. We have started to do some work, especially around the Makkalai Thedi Maruthuvam and the non-communicable diseases and lifestyle diseases medications. But again, I think information can be of great value, and the ability to test or monitor or measure on a regular basis for patients who are not coming to the primary health centers but staying at their homes through the Makkalai Thedi Maruthuvam teams can also yield great results. And as I say, the lessons from around the world and the lessons from our time in the COVID pandemic are that efficient administration, proper design, structural optimization and alignment can give us great benefits in the utilization of the large resources we spend. I think we spend about 30,000 crores a year, which we're happy to. But if we compare that to any large economy or advanced economy, it's not a great number. It's about 1.5% of GDP or GSDP. Many large countries spend 6, 7, 8, 10%. And yet they focus on efficiency. At 1.5%, our need to focus on efficiency and optimization is much higher. And so the message I would leave all of you today as you think about these things is, as important as scientific advances and research and clinical progression and the sophistication of prognosis is, as a state, as a government health department, as government administrators, we need to also think about a parallel improvement in efficiency that can greatly improve the scale of our reach and the size of our impact. Thank you very much for the time, and I hope you have a wonderful conference.
Honorable Minister, sir, with your permission, shall we open the forum for few questions from the audience? The forum is now open for 1 or 2 questions.
மாண்புமிகு அமைச்சர் அவர்களுக்கு வணக்கம். Sir, my question would be on financing, sir. Sir, Tamil Nadu is a pioneer state in constructing new medical colleges, and as of now we have 36 government colleges, sir. Sir, in 2016-17 budget, the overall expenditure for the health department is around 900 crores, of which both primary care and tertiary care had almost equal proportion. 27% of the allocation was given for both primary care and tertiary care, sir. Whereas,
sorry, sir, you mean 19,000 or 1900?
19, sir, total expenditure for health department was 9,072 crores.
9,000, okay.
9,072 crores, sir. Of which both primary care and tertiary care had 27% of allocation. Whereas in 2023-24, the total expenditure for health department was 18,660 crores, whereas primary care had 20% of the allocation and tertiary care had 34% of allocation. So my question is, sir, in this era of non-communicable diseases, where we have a greater role for primary care to avoid the burden for tertiary care, what is the government's approach on allocation to primary care and tertiary care, sir? Thank you, sir.
So it's difficult for me because I'm not the finance minister and I'm not the health minister. So I shouldn't speak about other people's books. But I am, since I was the finance minister when the 23-24 budget was read, then I'm a bit disappointed. I'm not sure that we break it that way, whether we break it the way you break it or you're able to extract that from the information. Certainly, if that is the allocation, I'm a bit concerned that we should be allocating a lot more towards primary care and a lot less towards tertiary care. But again, I only say that as a professional opinion. I can't speak officially. I'm not the minister for either department. In fact, that number surprises me a bit. I didn't think it had become so skewed, but if you say so, then I'm concerned.
பொது சுகாதாரத்துறையில் நாம் கடந்து வந்த பாதையையும் கடக்க வேண்டிய தூரத்தையும் வெளிச்சமிட்டு காட்டியதற்காக நன்றி ஐயா. மாண்புமிகு அமைச்சர் அவர்களுக்கு டிபிஹெச் ஐகான் 2023 நினைவு பரிசினை வழங்க மருத்துவர் TS செல்வவிநாயகம், இயக்குனர் பொது சுகாதாரம் மற்றும் நோய் தடுப்பு மருந்து துறை, சென்னை அவர்களையும், மருத்துவர் A சோமசுந்தரம், கூடுதல் இயக்குனர் PHC பொது சுகாதாரம் மற்றும் நோய் தடுப்பு மருந்து துறை, சென்னை அவர்களையும் அன்புடன் அழைக்கின்றோம். மாண்புமிகு அமைச்சர் அவர்களுக்கும் இயக்குனர் மற்றும் கூடுதல் இயக்குனர் அவர்களுக்கும் நன்றி.
No, I just got one piece of information that this allocation was not done by the finance department. So we just allocated the funds to the health department, and in the health department you balance the funds between the NHM and the state allocations, and you made this, you meaning somebody in the health department made this decision about the relative allocation. So at least I feel like I wasn't blindsided into doing something I didn't like to do. So I'm at least safe that way. Thank you.
கூடுதல் தகவலுக்கு நன்றி ஐயா. பலத்த கரவொலியுடன் அமைச்சர் அவர்களை வழி அனுப்புவோம். நன்றி.